use in children down to age 7, but the other one is not. So we will be talking in some respect about some off-label use. So we're going to focus really just on the management of diabetes in children in this talk. And although Kara will introduce a little bit of background on the insulin injections, the insulin analogs, we're really going to focus on the technology in diabetes, on insulin pumps and CGM. And then I'm going to talk a little bit at the end about what's in the pipeline or what's in development for future technologies in diabetes, particularly artificial pancreas or closed-loop pump systems. So diabetes is one of the more common chronic diseases in children. About 1 in every 400 children in the United States has diabetes. This is still mostly type 1. It ends up being about 200,000 children in the U.S. who are affected. And each year, about 15,000 new cases of type 1 diabetes are diagnosed, and a little over 3,000 cases of type 2 diabetes. In our population here, we primarily still see type 1 diabetes. Type 2 diabetes is gaining, particularly among teenagers who are obese and certain ethnic distributions, such as Native American and Hispanic patients. Type 1 diabetes, of course, I'm sure as you all know, refers to a form of diabetes in which autoimmunity against the beta cells of the islets is present, and this results in destruction of beta cells, and eventually patients are unable to make any of their own insulin. Therefore, they need insulin replacement therapy. Type 2 diabetes, children with type 2 diabetes are insulin resistant. They need more insulin to meet their body's needs. However, they also have a relative insulin insufficiency. And so this is a picture of an islet in type 1 diabetes showing a lymphocytic infiltration of the islet that results in destruction of the beta cells. So children, as you know, with type 1 diabetes, they must be on insulin therapy. This is the only way to treat them. And really the technology that we're talking about with insulin pumps and sensors has mainly been designed for people with type 1 diabetes, although they are sometimes used with type 2 diabetes. So why do we even need these technologies? Well, we know, of course, from many studies that controlling the blood sugar of these patients and maintaining strict glycemic control reduces the risk of long-term complications. Most people are very familiar with the A1C goal in adults, which is less than 7%. This was established in the Diabetes Control and Complications trial as the level that ultimately prevents having complications such as retinopathy and kidney disease. In children, it is more difficult to achieve an A1C under 7%, so the ADA goals in children are a little bit more lenient. The goals on the table up here are from the ADA, although the International Society for Pediatric and Adolescent Diabetes does advocate for less than 7.5% at all age groups. So with that in mind, I will move on to the treatment options for diabetes. And what I'm going to do here is have Kara pick it up next. She's going to talk to you about the currently available treatment technology, and then I will come back at the end and talk about the research development and future technologies.
All right, so am I on here? So what's current in type 1 diabetes? Can you hear me over this? Okay. So basically, NPH and regular insulin, they're essentially obsolete at this point. We typically don't prescribe that for kids that we see in our practice. Basal bolus therapy is the most physiologic approach to managing children with type 1 diabetes. This includes use of insulin pumps as well as use of glargine or detamir, plus rapid-acting insulin analogs such as Aspart, Lispro, or glulisine. One thing to keep in mind when working with children with type 1 diabetes that there is no dietary restrictions for children with diabetes. They can essentially eat whatever they want, whenever they want, as long as they cover it with insulin. And I love this last disclaimer here, of course, within usual childhood common sense guidelines. That doesn't give children with diabetes the right to, or they shouldn't be eating everything they want, such as, juice, pop, regular pop, et cetera, just as you would recommend any child. So healthy eating, of course, is important. This is a slide that shows some examples of the insulin action profiles. I won't go into a lot of detail of them, but just point out that with the basal insulin that we utilize, such as glargine and detamir, that they essentially have a duration of around 24 hours. And the goal of detamir and glargine is to essentially keep blood glucoses steady. We don't want to be using these basal insulins to essentially lower blood glucoses. So it's important when you're looking at blood glucose data that, if somebody is going to bed with a blood glucose that's in the 200s, if their basal insulin dose is adequate, they essentially will wake up with a blood glucose value that is in the 200s. So the rapid-acting insulin analogs, those typically tend to work, have a duration of around 3 hours typically, and I think that that's something that's really important to keep in mind as far as when children should be testing their blood glucoses. If somebody eats breakfast at 8 o'clock in the morning and takes a injection or a bolus of their rapid-acting insulin, if they were to test their blood sugar an hour later, we expect that their blood sugar is still going to be elevated. So that's just something that's helpful to keep in mind as far as when our optimum times for children to test their blood glucoses. I'm not going to get into much with this slide. I'm going to skip ahead here. So vial and syringes, those are not as commonly used for children at this point. However, they are quite helpful for children that are rather young, and for some of those children that are newly diagnosed and highly sensitive to insulin, they are quite nice to be able to dose in half-unit increments. So, and certainly, too, in utilizing syringes when you have to dilute insulin, we will sometimes prescribe U10 as well as U50 insulin. So you may see some syringes and vials still used. And it's not bad. Insulin pens, they offer an alternative to the use of syringes. They offer some benefits such as they're easy to carry and simple to use. You don't have to take out your vial and your syringe and draw up. You can simply dial up on the pen the amount of insulin that you want to administer prior to giving it. So they are available in both half-unit and whole-unit increments. And they also come, the whole unit increment rapid-acting insulin pens and the basal pens, rapid-acting insulin pens, they're available either in half-unit or whole-unit increments. The disposables, they all come in whole-unit increments, and the refillable pens where you would have the reusable pen delivery device as well as pen fill cartridges, those actually, some of them have the ability to dose in half-unit increments. And I think that that's one thing that is really key to remember when you're working with children with type 1 diabetes, particularly those that are rather young, that those reusable pen delivery devices that deliver in half-unit increments are really helpful because, well, as you can imagine, an extra half unit or less of a half a unit for kids that are rather insulin sensitive can be a pretty big deal. So keep that in mind if you're ever prescribing pens for kids. And some of these kids that are diagnosed, particularly at outside adult hospitals, I see them come in a lot into clinic, and especially for kids that are 4 or 5 years of age, and they've got a whole box of these flex pens or they're rapid-acting insulin pens, and it's rather challenging as far as managing their diabetes when we're only able to make dose adjustments that utilize whole unit increments. And some of these kids then walk out after their initial prescription fill from their pharmacy with having a 3-month supply, so it can be rather challenging. So I think that the ability to use some of these pens that deliver in half-unit increments for kids is really, really helpful. So insulin pumps, here are a few examples. I'm going to get into a little bit of the pumps that we typically utilize in our practice. The pumps have lots of wonderful features to them. They offer the ability to utilize multiple basal rates, and a lot of these pumps now actually are able to deliver their hourly basal rates in 0.025 unit increments, which is very helpful for being really precise with basal insulin delivery and for making changes, and especially not having to make very dramatic changes for those kids that are rather insulin sensitive. They offer the ability to use programmable basal patterns for activities. So kids, if they are participating in hockey, for example, every Monday, Wednesday, and Friday, and they tend to have issues with blood glucoses running lower in the overnight on those hockey nights, that you can actually set a different pattern for those kids to utilize for those nights. The pumps also have a nice feature too where you can utilize temporary basal rates, and I think that that's very helpful too, particularly for kids that are participating in unplanned activities. So we tend to notice that kids can have kids can tend to be more sensitive to insulin for up to 12 hours after their activities. So it's quite nice to be able to tell the pump to do a 20% reduction in their basal rate for 4 hours, 5 hours, even up to 12 hours. It's quite helpful to be able to use that. All of the pumps have the ability or have dose calculator features. That's wonderful for kids to be able to put in what their blood sugar is, put in how many grams of carb that they're going to eat, and have the pump do the math for what it would recommend for a bolus amount. All of the pumps, none of the pumps will just go ahead and deliver that. You have to actually look at what that recommended dose is and then confirm that you're okay with giving that. There are programmable alarms as well as reminders on the insulin pumps. I don't see a lot of kids using this, particularly for teens, because if you're ignoring testing your blood glucoses, it's rather easy to also ignore when your pump is alarming for the reminder. But it's certainly an option that's available. There are lockout features on the insulin pumps, so that can assist with helping kids from accidentally administering a bolus of insulin with their insulin pump. And some of the pumps, such as the one-touch ping pump, that actually has the ability to bolus using their meter directly to the pump. And I think that that's a really nice feature of the Animas pump for small children, because as you can imagine, if you've got a toddler that's running around, if you have to actually stop them, take a pump out of their pump pack to be able to deliver insulin, it can be a little bit challenging rather than just holding the meter next to the child and bolusing without having to necessarily stop them. The Medtronic pump to date is the only pump that is glucose, that is compatible with the continuous glucose monitor. Here's an example of the most current pump from Medtronic. This is the Medtronic Paradigm Revel. This next one is an example of the Animas Ping insulin pump. And here's an example of the Omnipod insulin pump. That is the one that's to the left. This one is unique in that it's the only patch therapy that's on the market to date. And a lot of kids really like not having the tubing aspect of it. So, and you're able to bolus using what they call the personal diabetes manager, the PDM. A lot of people call it the PDA, but it's the PDM. So, the other one to the right is the AccuCheck Spirit. I don't see that as commonly used in our practice, although I believe we have maybe 1 to 2 patients in our practice that use this pump. This is a picture of one of the newer pumps that's now on the market. It's the Tandem T-Slim. This one actually has a touch screen to it, kind of like your smartphone. So I think that we'll be seeing this pump coming through in our group at some point. I can see where it might be appealing to adolescents and young adults. I get a little nervous, I guess, thinking about the ability for a touch screen for somebody like a toddler, but I guess there is a feature to be able to lock it out. But you can imagine, I think of my 3.5-year-old and my iPhone, and he's pretty rough with that. I can't imagine how he would actually be with this type of a pump. But I think we'll soon be seeing this coming through in our practice. So some things to consider with insulin pump use. Insulin pumps can fail. Typically, it ends up being an issue with the infusion set. The infusion sets go in with a needle that is removed, and what's left in place is a plastic cannula. And as you can imagine, if there's some kind of an issue at insertion where that cannula gets kinked, it's like a garden hose, and there will be no insulin delivery. And with most of these infusion sets, you're not able to tell that there's actually something wrong with the cannula that's left in place. you won't typically see that there's insulin leaking. So it's something that you always need to keep in the back of your mind when you are working with kids with diabetes that are utilizing insulin pumps, particularly if they're having high blood sugars, that insulin pump failure certainly could be a cause of their high blood sugars. So one of the concerns with using an insulin pump, if there's a set failure, is that there's no longer any background insulin on board. There's no glargine or detamir on board. So kids that are utilizing insulin pumps can actually, if their pump set fails or their pump fails, they can actually start to develop ketones within 3 to 4 hours. And whenever ketones are present, injections are absolutely recommended to be given until those ketones are cleared. I've worked with a number of families that unfortunately it ends up being a very hard lesson to learn, that they see high blood glucoses with their child and they continue to bolus utilizing that insulin pump, and there's something wrong with the infusion set, and it's not until their child is in DKA that they realize that, oh, there's something actually wrong with the actual infusion set. So it's a hard lesson to learn, but it's something that we really need to be mindful of, that if there's high blood sugars, always consider that there could be something wrong with the insulin pump or the infusion set, and to absolutely change out that infusion set. It's recommended for kids that are utilizing insulin pumps to test for ketones whenever they are having persistent hyperglycemia. A lot of our group was at diabetes camp last week, and I can give you lots of different examples and reminders that we were giving some of the campers, as well as even the counselors. I had a very smart, beautiful counselor that was in one of the cabins I was working with, and I overheard her say, gosh, my blood sugar was high before I went to bed. I gave a correction bolus. I still woke up and my blood sugar was high, and my correction doesn't really seem to be working. And I looked at her and I said, take out your syringe, give an injection. And she kind of thought, oh, yeah. So it doesn't always occur to people to, pull out a syringe, pull out a pen, get an injection, fix that high blood sugar, and you can certainly worry about that technology second after you've fixed your high blood sugar or ketones. So as far as insulin pump research, many of the studies comparing insulin pump use to multiple daily injection therapy demonstrated an improvement in hemoglobin A1C levels in those utilizing insulin pump therapy. However, the majority of studies show that over time, many of those improvements in hemoglobin A1C were not sustained. So it's something to keep in mind that certainly when children go on insulin pumps, it's not going to fix issues that they might be having with blood glucose control. It certainly is a wonderful tool. There are lots of wonderful features to the insulin pumps that I think are very helpful for children. Studies, however, looking at patient satisfaction when they're utilizing insulin pump therapy really predominantly show that people tend to be much happier when they are using insulin pumps. So that's something to keep in mind. I'd say that maybe roughly half of our kids are utilizing insulin pumps, and maybe 70% here? Okay. So 70% of kids here in our group are utilizing insulin pumps, and then the other remaining either just don't prefer to have something attached to their body, or they might not just be ideal candidates for insulin pump usage. It's always a good idea to make sure that kids are testing their blood glucoses adequately when they're utilizing insulin pumps, because if you're not testing, you're not going to pick up that there's something wrong with your infusion set, and that could be a problem. So I'm going to talk next about continuous glucose monitor sensors. There are many wonderful benefits to the use of CGMS, such as being able to easily know an estimation of your blood glucose levels. The sensors all have arrows that will either they point up or they point down depending on where blood glucoses are trending. And so it's helpful to be able to anticipate glucose changes. There was a camper in one of the Sorry, I know I'm bringing up a lot of examples from diabetes camp from last week, but I had a really cute little camper that had a sensor that she was utilizing, and I, with my years of experience, was going to give her a recommendation to decrease her basal rate for a while overnight, just based on where her numbers have been running during the day. And she pulled out her sensor and pointed to the arrows going up and said, "I don't think that we should do that." Okay. So it certainly can be helpful to utilize that. They also can be helpful for avoiding oncoming lows as well as high blood glucoses. And really, I think one of the most important things, or one of the most important aspects of the use of CGMS is that it's a really wonderful tool for picking up trends. So I think a lot of the families that end up being truly successful with the use of CGMS are really using it just to pick up trends. Some important things to keep in mind with the use of CGMS is that there is no CGMS on the market that is FDA approved to dose insulin based on sensor values. So if you're working with children or parents that are expressing interest with the use of CGMS to avoid finger sticks, that's not the ideal reason to go on one of these. Finger stick glucose testing is, of course, still required. Here are a couple examples of some of the continuous glucose monitor sensors that are available on the market. Up top, this is the latest and greatest version from Dexcom. It's called the G4. I think it's kind of actually an intense name, but G4. And then the one below this is an example of the Medtronic Guardian, but this is very similar to what the sensor and the readings would look like if you were utilizing the Medtronic Paradigm Revel pump with the sensor capability. So the real-time continuous glucose monitors, they offer a lot of information. Sometimes I think that information can be a little overwhelming for families. They provide glucose readings every 5 minutes. The CGMS actually measures interstitial glucose values, so they are not going to be exactly the same as what kids are finding when they test their blood glucoses via finger stick. These sensors, they all require calibration, a minimum of 2 times per day to up to 4 times per day. So again, just a key thing to remember that these do not eliminate the need for finger sticks. These sensors are FDA approved to change every 3 days to up to every 7 days. There are alarms on these, so certainly you can get alarms if blood glucoses if there's a predicted issue with an oncoming low blood glucose, as well as if there are issues with high blood glucoses. But again, not to pick on adolescents, but I've had parents that have expressed interest in clinic with their teen going on a CGMS, and for the reason that they want the alarms to remind their child to test or administer insulin when it's alarming. Teens will ignore the alarms. It's not usually the best tool in that circumstance. So the Dexcom is approved for ages 18 and up. We do see this. We do prescribe this, however, off-label, so it is utilized in children under that age in our clinical practice, but FDA approval for this one is for ages 18 and up. The Medtronic CGMS is approved for children ages 7 and up. So as far as looking at the research that's available for the use of CGMS, it's appropriate for the motivated user. There was a study that shows that there's up to a 0.5% reduction in hemoglobin A1C in adult patients. I believe they were over the age of 25 who wore the sensor for at least 6 days per week. And they found, and again, not to pick on teens, but they found little benefit in adolescents in the early studies. So part of it's just, you have to have extra real estate too. You've got a pump and a sensor on in one spot, and then you have to have a sensor in another spot. And not every adolescent is very willing to have all of that technology on their body. So in conclusion, CGMS can be a wonderful benefit for glycemic control in the motivated patients. And I do think that it certainly can be a really good benefit too for predicting highs or lows for some families, particularly with some young children. Here is an example of what we utilize on occasion for kids in our practice. This is called the iPro. This is from Medtronic. We can place a glucose sensor on children in clinic that's blinded to the patient, and then when they come in, We will download this and we'll be able to pick up trends for where blood glucoses have been for. It's approved to be worn for 3 days. I have had kids that have been able to wear it for slightly longer than that. It's a lot of information to look at. Essentially, you're looking at 288 data points per day, but it's a wonderful tool for trying to figure out things that we might not be catching with just finger stick blood glucose testing.
All right, so the rest of this is going to be about technology that is mostly not currently available and certainly not currently available in the U.S., but builds right upon what Kara was talking about with the currently available insulin pumps and integrating sensor technology with the pumps for a more automated control system. And so you might say, well, we have this great technology. Why do we need something different? Why do we need advancements? Well, the simple fact is that most people with type 1 diabetes actually aren't making their A1C goals. It's a very, very effort-intensive disease to control. And this is data that is from a study in adult subjects, but we actually have more child and teen data now coming out of a national registry, a type 1 diabetes registry, that basically says the same thing, which is 2/3 or more of patients with type 1 diabetes, children, and a bigger proportion of adolescents are not meeting their goals for age for their hemoglobin A1C. And part of that is just that it's a very difficult adherence regimen to be bolusing for everything you eat and precisely counting your carbs. And so one of the hopes with the future, one of the possible future treatments of diabetes is going to be to have a more automated system where the insulin really responds to what the blood sugar is. So people will refer to this as the artificial pancreas. So sort of globally thinking of this concept of the artificial pancreas, there are a couple approaches that one could take. You can have a external model artificial pancreas. That's the approach I'm really going to be talking about because that's what's under development in the U.S. So this builds upon the technology Kara was talking about. The idea is that you wear a continuous glucose monitoring sensor. The sensor beams the blood sugar to the pump, and instead of the pump just reading it out now the pump actually calculates what dose of insulin do you need and automatically delivers it. There are some limitations in achieving this that I'll talk about, barriers including the fact that you have to know not only what is that patient right now, but what are they going to be an hour from now, 2 hours from now, activity, food intake are all going to affect blood sugars. And unlike our own pancreas insulin, which is very instantaneous in action, so our islets make insulin, that effect happens within 10 to 30 minutes and is gone, and there's a very instantaneous response. Insulin analogs, at the very minimum, last for 2 hours. So even our fastest acting insulin for most patients is acting beyond 2 hours, out to 3 to 4 hours. So we give insulin through a pump, it lasts for a while. The other approach would be to do an internal artificial pancreas. This might be something that was a little more physiologic in the sense that you could have an implantable sensor that's directly reading blood glucose rather than interstitial glucose, and you could have a pump that's secreting insulin IV that's more rapid acting. Obviously, there are some other limitations to this approach in terms of needing a surgically implanted device, and there are some limited studies with implantable pumps, but really isn't something that, to my knowledge, is being developed right now in the U.S., so I'm going to not talk much more about that internal approach. But regardless of whatever approach you are taking, there are really three basic things that we need to have nailed down to have a good artificial pancreas. The first is that you need the insulin delivery system, so you need the insulin pump, whether it be an external pump or an internal pump. You need reliable glucose sensors, so you need something to tell the system what is the blood sugar. And then you need some sort of algorithm that controls the insulin delivery based on the blood sugar. So these are the three basic parts to the artificial pancreas. So the limitations, as I've already mentioned, some are with the insulin pump or the insulin delivery. Our current insulin analogs, even the fastest acting forms, have a pretty good effect out to 2 hours and a tail out to 3 to 4 hours. So it's hard for a pump or a sensor to anticipate if that person's going to be exercising an hour from now or eating an hour and a half from now. So there's a little limitation in our insulin analogs in the delivery system. With regards to the sensors, they are pretty good right now. They're not 100% accurate. The accuracy studies and accurate in diabetes technology usually means is either accurate or it's off enough that the intervention you give wouldn't have been different. So, that kind of combined accuracy is about 90% for the current sensor technology, so it's not 100% accurate. And sensors, much like pumps, can fail. So you need a sensor that's going to be accurate and reliable and continue working. Some of the workarounds with that right now are actually to do double sensor systems. So you put in more than one sensor so that you have a backup. And then the control algorithms, I won't pretend I could tell you what that's saying at the bottom, but there's more than one approach to a mathematical model to control the pumps. So these are complicated algorithms that incorporate not only what's happening now, but rate of change and anticipated blood sugar. So this would be a schematic example of what a closed-loop pump system might look like on a patient. They have their continuous glucose monitor. That's what's over on your right side, the left side of this patient. They have their pump system, and they have this blood sugar reading, which I think is displayed in this top bar here. And then they have different rates of insulin delivery, which is displayed in these bottom two bars. So things are constantly changing in terms of insulin delivery in response to the ambient blood glucose and change in blood glucose. So where are we at now with closed-loop pumps? Well, they are actively under study in the United States. In fact, there's quite a bit of study on closed-loop pump systems in the U.S. right now with very promising initial data. But I'll say that this is still really limited largely to inpatient studies of limited duration. So usually 72 hours or less on a closed-loop pump system in a research center or an inpatient environment that's highly controlled. They are just now getting to stages of outpatient therapy and longer therapy. There is actually some limited closed-loop pump therapy, very limited closed-loop pump therapy that is available in Europe and hopefully will be coming to the U.S. soon. And this is in form of a sensor that directs the pump to suspend insulin for 2 hours in response to hypoglycemia. So basically, this has been well studied. It's been on the market since 2009 in Europe, used by thousands of patients. And has over 50,000 patient days of data that's been analyzed that show it's safe. So hopefully it will come to the U.S. soon. But basically what happens with this pump model is that as blood sugar is dropping, which is what's in this figure here. Let's see if I have a cursor. Okay. Blood sugar is dropping here in this particular example. So this is data from many, many, many different subjects. And so average blood sugar gets down to under 80, down to 70, and the pump automatically suspends insulin delivery. And unless you override the system, so daytime you're awake, you override the system saying, yep, I know I'm low, I heard the alarm, I'm treating myself. If you don't override that alarm, it stops the insulin for a full 2 hours. And so what happens during that 2 hours of suspended insulin delivery is the blood sugar gradually rises because there's no insulin on board. The studies are very consistent that the blood sugar on average gets to about a level of 100. The insulin then resumes, just as an automatic function of time, 2 hours, the insulin resumes. Of course, it takes a little while for the insulin analog to kind of get on board, so there's some continuing rise in blood sugar, but it's very modest, and these studies really show that the blood sugar kind of stabilizes out around 150, so there's not a rebound hyperglycemia here. It seems like a very, very safe system for overnight management of blood sugars, particularly reassuring for parents who might be worried about nocturnal hypoglycemia or patients who have had problems with nocturnal hypoglycemia or nocturnal seizures. So this is kind of the first step in the closed-loop pump system, and hopefully over time what will happen is this will get to a more longer periods of control, overnight control, and then daytime control with the blood sugar actually controlling insulin delivery, not just suspending insulin delivery. So I'll give you just a few examples of research that's being done on closed-loop pump systems, specifically in adolescents and children. So these systems have been studied in teenagers and now even in children younger than the age of 7. This is a particular example from teenagers that I thought kind of illustrated nicely the not perfect but tighter control that you can get with a closed-loop pump system. So these particular patients were in a research environment for 36 hours, either just on their standard insulin pump therapy, and then they were crossed over to the closed-loop pump delivery system. And this figure that's called figure A here shows percent of time that they were in target range, which for this particular study they were targeting 71 to 180. So you can see what happens is there's not everyone's doing poorly on their insulin pump, but there is a huge variation over this 36 hours in percent of time that was spent in target range. And when you switched them over to the closed-loop pump, that really narrowed up, and people were spending most of their time in that target range. And you see a similar thing happen with their mean blood sugar, very variable mean blood sugar among the patients on the insulin pump therapy. You switch them over to the closed-loop system, and this really hovers right around 130, 140 for an average blood sugar. So you're able to maintain, at least in this controlled environment, reasonably good control. There are the standard insulin pumps, as I showed you, just controlling insulin delivery in response to blood sugar, and then there are variations that have been proposed and are under development. So people have proposed maybe more of what they call a hybrid closed loop instead of a full closed loop, because the pump can't really anticipate when someone's going to start eating, and then the blood sugar goes up pretty quickly and the pump has to respond. There's always this period of postprandial hyperglycemia with the closed loop pump systems. So one approach is to have a patient do a set bolus. So it still involves some patient work, but it's pretty easy. The patient takes a bolus, for example, a unit every time they're going to eat. That gets some insulin on board so that they have less of a hyperglycemic excursion. There are people who are actively developing bihormonal pumps, and what that means is that the pump actually contains both insulin and glucagon and regulates insulin and glucagon differentially. So this would be much more similar to an actual pancreas, right? An actual islet that you know, the islets in our body within our native pancreas, they make insulin as our blood sugar rises, but once the blood sugar falls to 70, insulin secretion is turned off, glucagon is turned on, and these pump systems would work similar to that. So the idea behind a bihormonal pump is that you might have less hypoglycemia on the pump system. And then, of course, the initial systems that have been studied in the hospital involve big computer systems that can't be lugged around with you, so more outpatient-friendly systems are being developed. So I'll give you just a couple examples of each of these. So this is an example of a hybrid closed-loop pump compared to a full closed-loop pump. And if you just only look, I guess, draw your attention to this bottom one here. This is blood sugar control, with the dark black line being blood sugar control on a hybrid closed-loop pump where the patient actually gives a set bolus with each meal, compared to a full closed-loop pump where you just wait for the pump to respond. And so what these studies have demonstrated is if you give a small bolus manually before a meal, you still have some hyperglycemia excursion with the meal, but it's much less than if you just wait for the blood sugar to go up and wait for the pump to respond. So this is one possible modified approach. This just displays what would happen with a bihormonal pump, where there is both insulin and glucagon present in the pump system. In this case, what they're showing is blood sugar here in the red line. This is blood sugar falling towards a level that would be equivalent to 70 milligrams per deciliter. Blue is insulin secretion, so you see variable insulin secretion depending on the blood sugar. Insulin turns off, but in this case, the pump gives a bolus of glucagon, a small bolus of glucagon, and this helps bring the blood sugar back up so that there's less time spent in hypoglycemia here. These approaches, from the data I've seen, have been shown to minimize hypoglycemia. There's a real challenge here, though, with glucagon, and that glucagon does not stay stable in a soluble form for more than 24 hours, and it's very expensive. So really, for this to come to the market, they also require, on the pharmaceutical side, development of a more stable liquid form of glucagon. And then there are people who are developing outpatient systems, and this is one example that hasn't been tested for efficacy, but just sort of feasibility of where, and that the signal doesn't drop, and showed that they could maintain signal with this pump system and sensor system for about 99% of the time that the user was wearing it. And they used, in this case, what was basically kind of a smartphone technology to direct the insulin delivery. So something that actually could be worn for weeks at a time in an outpatient setting. So in summary, so that's kind of where the research is at in terms of closed-loop pumps. But to summarize everything here, basal bolus insulin regimens are the mainstay of type 1 treatment right now. And most often in type 1 diabetes, or in the majority of our type 1 diabetic children, we give this by insulin pumps. That's not because they can't get good control with multiple daily injections, but as Kara said, there are some features in terms of fine-tuning that can really benefit children on insulin pumps, and patients tend to be more satisfied with insulin pump delivery. As a provider for these patients in a kind of the non-diabetes world in the hospital, if you had to remember one pearl out of what Kara said, I think it would be that if you have a patient who is hyperglycemic on a pump, that you remember that infusion site might have failed, and you need to change out their infusion site and get them reliable insulin delivery. Continuous glucose monitoring systems can improve glycemic control in motivated patients, but as Kara emphasized multiple times, it does not replace fingerstick blood glucose monitoring. Very important, because the most common reason, as Kara said, that someone comes in and asks for a CGM is that they don't want to check their fingerstick blood sugar. If anything, it's a little bit more work to have a CGM system, and so people really need to keep that in mind when a patient is interested in CGM. And the next step, hopefully, will be these closed-loop CGM pump systems, or the artificial pancreas, which are under development now, and the automated suspend for hypoglycemia is available in Europe already, and hopefully will soon be available in the US. And because we were talking about diabetes technology, I thought it was only appropriate to leave you with a cartoon about smartphone technology and diabetes that someone sent to me the other week. Thank you. And we'll take any questions. Yeah.
Speak at all to intranasal or oral. Occasionally they'll talk about what you'll read about sublingual insulin, or there was an inhalation.
There was an inhalation insulin. So their oral insulin is actually something that's been used in type 1 diabetes prevention trials. So oral insulin gets degraded in the gut to peptides. So for people who are sensitized with insulin antibodies who haven't yet developed diabetes but are expected to go on to develop diabetes, oral insulin is being studied as sort of a therapy to create tolerance with the immune system and prevent progression to diabetes, but not so much as a treatment approach. But you're right, there have been inhaled insulin analogs that have been studied. There was one from Pfizer that was on the market for a while, and they pulled it off of the market because there was a small increased risk of lung cancer in adults who smoked and used inhaled insulin. It's not actually something that's been studied or used in children at this point. I'm told there is another company that has inhaled insulin under development, though.
What about using islet cells and putting them in the detection devices themselves? Can you get enough cells in whatever?
Yeah, so the question being about what about using islet cells in one of these devices. And so there are that kind of approach is also under development, sort of separate from this technology, but there are a lot of people who are studying taking islets in some sort of encapsulated bioengineered device that would be immune protected and would also then kind of function as a sort of an ectopic or artificial pancreas. And islet cells are great in that they already have their set point programmed, and they have both insulin and glucagon. And so if we can feasibly make that work, that also would be an ideal approach. The main challenge is being finding an environment, a protective environment that actually protects from immunity but allows enough oxygen and nutrients in to sustain islet viability, and that's the biggest part of the challenge. But there are some promising studies in terms of encapsulation devices as well. Yeah? No, I'm not sure about number of ED visits, but I can tell you that so one of the concerns about insulin pumps initially was that there was some literature that suggested maybe increased severe decay or mortality from decay for people who were on pumps, mainly because of that non-adherent group who didn't notice that their insulin delivery was interrupted, and now they're no longer getting a long-acting insulin analog like Lantus that would prevent them from getting ketotic, right? So when you change over to a pump and all of your insulin delivery is as Novolog or Humalog or one of the forms of rapid-acting insulin, when that pump gets kinked off or there's a problem with it and the pump doesn't necessarily alert you to it, you lose all of your insulin delivery in 4 hours, hyperglycemia develops, and then if you don't detect the hyperglycemia, you go into decay. So in theory, there's a little bit more of a risk of decay with pumps. Now, the abstract that I saw most recently come out of the Type 1 Diabetes Exchange, and Brandon or Tony can jump in if they remember something different, is actually that it was very similar decay rates among pumpers and injections is actually the more recent data that's come out.
And I think that's just a plug for the importance of very good education from a diabetes educator prior to kids going on an insulin pump.
No, I agree. We actually, even though we have families who forget that and learn the hard way, that is one of our components of the diabetes education, is to really emphasize. So we'll say things like, when in doubt, change it out. If you're having hyperglycemia, just change your site. and put in a new one to make sure you have reliable insulin delivery. Problem is that when that little tiny catheter that's under the skin kinks, the pump doesn't necessarily give any signal. It doesn't say occlusion or doesn't indicate there's a problem. And then people will take the pump site out and they'll say, oh, the catheter was kinked over sideways and there's nothing coming through it. So you can really see it sometimes once you pull it out and put a new one in. But there's no way you know until you put a new one in.
Which is a good reason not to change pump sets prior to bedtime.
Yes, yeah. Kara pointed out another thing that we actually tell families is that we prefer them to change their pump sites earlier in the day rather than later, or if they change a pump site right before a kid goes to bed, to check in 3 or 4 hours, because if the pump site goes in poorly, they may get hyperglycemic overnight and be ketotic in the morning. Yeah, Greg.
Can you talk at all about the development of ultra-rapid insulins and other attempts to kind of
Yeah.
these?
Yeah, no, I think that's a very good point, and I'm not sure exactly where they are at with the ultra-rapid acting insulins right now in terms of how close that is to actual clinical setting. But one of the pieces that would actually improve the feasibility of the closed-loop pump technology for everyday use, as Greg is pointing out, is actual faster-acting insulin. So there are pharmaceutical companies that are working on developing what we call ultra-rapid acting insulin. So it actually would work faster than these 2 to 4 hour insulin analogs and would solve some of those issues with, having to anticipate 3 or 4 hours down the road what's going to happen. All right, well, thank you.